Sorry about that. My lights went out. So let me restart. Now again, right? When we're looking at the parietal pleura right here, anytime we have a disruption of the parietal pleura, there's always a risk of a collapsed lung. And keep in mind, it doesn't take much, right? Any kind of disruption. All the doctor did for the San Diego Chargers quarterback was accidentally puncture through a small part of the parietal pleura. That caused a partially collapsed lung, right? He has not played since, and I believe this happened in like, a month ago, right? Because it does take time for that parietal pleura to reseal itself. And it is very distressing, right? When you can't it feels like you can't take a deep breath. So keep that in mind. What is a parietal pleura? That's that connective tissue that we see under the ribs when we cook meat. That's a parietal pleura. So when you're cooking ribs next time, just pay attention to that. Make you not want to eat the ribs, I know, right? But that is a parietal pleura. And it covers both sides. It covers the area in the mediastinum, and it allows us to then have a vacuum seal around the whole thoracic cavity. So there should never, ever be any free space, right? Any air, right, found in the actual space between your parietal and the visceral pleura. Never. If there's even any air in that area, that means you punctured that parietal pleura, and now you're gonna have a collapsed lung, or what we call a pneumothorax. Now, I know in our class, when we talked about ribs last semester, we're always careful, right? And I had you memorize, I don't know if you guys remember it, Jose, all right, that Jessica, that when we looked at the ribs, there was a reason why I wanted you to know that costal groove found on the inferior aspect of each rib. And the reason why is that in that costal groove, you have lots of arteries, veins, and more importantly, nerves. So when when people have a collapsed lung and it's big enough, they have to put a chest tube in. So what a chest tube would do is remove any free air from between the parietal and the visceral pleura. It's going to suction that air out, and now we have a vacuum seal again, right? Now, we keep the chest tube in long enough for the parietal pleura to recover and form a complete seal again, right? But when we put a chest tube in, we don't just willy-nilly just put the chest tube in. We try to look at the base of your lung, all right, as low as we can. And what we're gonna do is go inferior to that costal groove. So we find that, like second, third last rib, and we look at the superior edge of that rib away from the costal groove. And we try to cut with a scalpel as close to that superior edge of that last rib as we can. As we do so, we're going to cut through the parietal pleura there, put in a vacuum, kind of tubing in there, and it'll suck up any free air and any blood that's found in the space between the parietal and the visceral pleura. Again, real world consequences of what we mentioned last semester, right? Now, when a lung collapses, and this has been a parietal pleura, outer layer adherent to the wall of the thoracic cavity, visceral pleura, inner layer covering the lungs itself. It is the movement of the parietal pleura which pulls on the visceral pleura, which then allows the increase in volume of the lung matter. When there's any free air in it, it can cause a collapse, and we have a pneumothorax. Now, usually, if it's due to trauma, you'll also have blood in there. We'll have a hemothorax associated with it. Now, keep in mind, here's the weird part. The weird part is this. In kids, and even young adults, they can get an idiopathic pneumothorax. For some reason, and it's usually adults that are in incredible shape that this happens to. I had a student a few years ago. Now I said a few years, it might be about 8, 9 years ago, maybe 10, all right? She was in incredible shape. You just see her, she's just athletic, right? Very muscular, very athletic, not like bodybuilding athletic, but still, like athletic kind of look to her. And she would run miles and miles a day. Yet when she came to school, she had a hard time walking up 5 flights of stairs, she said. She couldn't walk it without stopping. She couldn't walk it without, having a real hard time, right? And she shouldn't have. And she went to the doctor and she went to the ER. ER didn't even bother doing a chest x-ray. At first, I didn't think anything of it, right? I'm like, well, maybe she's just tired. Maybe she's sick, right? So she went to the ER. They didn't do anything. They thought it was anxiety, right? So the next week she comes back to school and she complained the same thing. At this point, I'm like, well, maybe it's something else, right? I was hoping it wasn't a pulmonary emboli or anything, because that could happen in somebody that's young and in shape as well. So I made her go back to the ER again. And this time I made her demand a chest x-ray before they made her, if they do anything, I told her to just make sure they do a chest x-ray, right? Just to see if there's nothing wrong. She had a collapsed lung on one side of on the right side of her thorax. And it wasn't just a partial collapse. It was a completely atelectic collapsed lung. And you can really see, and what happens is when there's free air in the actual thoracic cavity, the lung matter there retracts. The bronchi and the actual, the trachea actually moves to the opposite side of the affected side. So you could actually see the shift of the trachea because of collapsed lung. And we could see it, and she checked, showed me the chest x-ray. You could definitely see the retraction of the lung matter. So she was breathing with just one lung, in other words, right? And it happened this whole time. Eventually, when they saw the x-ray, obviously, they then put a chest tube, reinflate, but she was out of school for about 2 weeks, right? But that does happen. She wasn't in any car accident. She didn't have any kind of trauma. It just happens for some reason in people who are in amazing shape. And it can happen in males and females. And another student that was a male that actually had this happen too, and it continues to happen to him. He's like 34, 35 when I had him in my class, and he goes, I still have these episodes, and they don't know why. I'm like, yeah, you have idiopathic pneumothorax. We don't know why. It just happens. But it's still a pneumothorax, right? If it's small enough, you can probably recover without a chest tube. But if it's large and there's retraction of the lung matter, there's deviation of the trachea, you need to put a chest tube in. That does happen. Now, when we look at blood and lymphatic system, there's 2 sources of blood going to the lungs. The first one's simple, right? The first one is for the rest of the body. The pulmonary artery brings deoxygenated blood to the lungs from the right ventricle. That deoxygenated blood goes through the capillary beds that surrounds the external aspect of the alveoli. Blood leaves then through the pulmonary veins and returns to the left atrium. The other blood supply is for the actual lung matter. This is like the vasa vasorum, right? Vasa vasorum was the blood vessels that bring nutrients to the blood vessels, to the cells that make up your blood vessels. So what we're going to see here is bronchial arteries. And that's one of the things I want you to know for the lab practical, right? A bronchial artery is slightly different. Whoops, I need to do that. Bronchial artery is going to bring, is going to branch the capillaries and bring nutrients to the smooth muscle cells that make up your bronchioles, to the cells, the simple squamish cells, they make up your alveoli, right? They need to have glucose and nutrients as well. They can't receive it from the pulmonary veins, right? So what do? They receive it from a different source of blood vessels, the bronchial arteries. Right, part of this now deoxygenated blood then exits through the bronchial veins to the azygos. Heart merges with blood of alveolar capillaries and returns to the left side of the heart. So just understand that we have bronchial arteries, Bronchial arteries bring nutrients, removes waste from the cells that make up your distal respiratory system. Now, two lymphatic supplies, superficial and deep lymphatic vessels. They exit from the hilus. The important thing about it, they drain, deep drain bronchi and associated connective tissue. We're going to see, right, and I'm going to show you pictures in a few minutes. There's a certain condition called sarcoidosis that affects primarily African American females. And one of the things that I have you kind of memorize the hilum of the lung and the hilar lymphatic supply, right? Lymphatic nodes in the hilum. Well, there's a reason why I want you to know these. It's because sometimes you will see an x-ray where there's going to be an enlargement of the hilar lymph nodes, and it's telltale, right? It is specific for sarcoidosis. All right, we say when you see that sign, and we know you should be thinking about only that disease, that it's pathognomonic for that disease. Having infiltration of our hilar lymph nodes, right? We call it hilar lymph adenopathy. Well, that is pathognomonic for sarcoidosis. If we see it on a chest x-ray, immediately, that's enough for us to diagnose sarcoidosis. Obviously, we'll also do an HMP as well, so then we can tell the progression of disease. All right, ventilation. Ventilation is a movement of air in and out of the lungs, right? That's ventilation. So we're going to use certain words now that are going to sound identical: ventilation, respiration, right? But ventilation is the actual movement of air. Respiration is the movement of blood that contains that now fully oxygenated red blood cell. All right, so ventilation, movement of air into and out of lungs, and air always moves from higher pressure to lower pressure. Makes sense, right? So that's true for blood. That's true for any liquid and any gas. So in order to move any liquid, any gas, you got to create greater pressure in the direction you wanted to go to. Boyle's law, they have that K, which is a constant for that gas, right? And keep in mind the constant at a given temperature of that gas. Well, when we talk about our environment, it's a mixture of gases. So it'll be different Ks, but it's still constant. We don't really worry much about, this kind of K value when we talk about physiology, especially in the 200 level class. Maybe when you're in graduate school or something, they'll talk a little bit more about how to find these answers completely. But for our class, I want you to know the concepts. And it is, how is pressure related to the volume? Right? And we discuss it, and it's right here. Pressure is inversely proportional to volume. So as a volume enlarges, the thorax increases in size because of the diaphragmatic contraction. The pressure in the thorax and in the lung matter drops. Inverse relationship, not a direct relationship. Here's a picture of what happens here. Now keep in mind, we need to somehow get air into our lungs. In order to get into our lungs, we need greater pressure from the environment, lesser pressure in our ribs and into our lung matter. Now, we're not really going to increase the amount of pressure in our environment. That's going to stay stable, right? So it's not like all of a sudden you can make the barometric pressure in your room increase 10%, so then you can breathe easier. Can't do that. So how can we have a change in pressure then? So then there's more pressure, relatively more pressure in the environment, less pressure in the lungs. We do it by Boyle's law, right? As your diaphragm contracts, thorax expands, your parietal pleura expands with it. The parietal pleura then pulls on the visceral pleura. As it pulls on the visceral pleura, the alveolar cells enlarge. Alveolar cells enlarge, your lungs expand. As the lungs expand, what happens in Boyle's law when you have increased volume? You have a pressure drop. Not a huge pressure drop. Here we're talking about -1, -2 millimeters of mercury. That's all, right? But it is a pressure drop. Now we have negative pressure in the lungs. The environmental pressure doesn't change. So now, relative to the lung pressure, right, there's going to be a difference now. So air is going to go from the environment through the bronchi into the lung matter. When you exhale, right, diaphragm moves up, then you have a sudden movement of the ribs and the thorax, decreasing the size, causing a pressure increase. The pressure increase then ejects that air outwards, and you can expirate. In order to do this, though, you need to have that seal, right? When people have a disruption of the parietal pleural, the rib cage will still move back and forth, but you can't pull on the lungs, and the lungs don't move with the rib cage anymore, right? And that's because now, because of that disruption, air from the outside moves in to the thoracic cavity, and it becomes a physical hindrance. So then the thorax, even though it's opening and, increasing in size and decreasing in size, right? The thorax is, but because of the rupture of the parietal pleura, the lungs can't move with it. Now, changing alveolar volume, elastic recoil allows for the exhalation of air, right? Contains elastic fibers in the alveolar wall. We'll also see that in order to have our alveolar cells kind of open up, we have some forces that are going to go against it. We're going to have surface tension, film of fluid lining the alveoli, where water interfaces with air. Polar water molecules have great attraction to each other, with a net pull towards other molecules. The surface tension found in the alveolar region has a tendency to make the alveoli collapse. That's a part I want you to understand right there. So surface tension allows and actually is a negative hindering factor for our alveoli to expand. It causes the alveoli to collapse. I want you to think about a balloon, a very small balloon. What happens when you first try to blow into a very small balloon? There's a lot of surface tension on the small balloon. Now, instead of a small balloon, think of a tiny microscopic balloon, right? You can imagine the tension it has to kind of, right, to go against the force of air going through. The smaller the balloon, the more the surface tension. You have a large balloon, it's pretty easy to get air in. But you have a small balloon, there's a little bit more surface tension. So what do? We kind of like stretch the balloon, right? That kind of stuff. And then you can start putting a little bit of air in it, right? Our alveoli are very similar to those small balloons. So what happens when you first put air into the balloon, a small balloon, and you keep pumping it up? What happens if you let go all of a sudden, right? Normally, as you're pumping it, you have to catch your breath. So then you put your fingers over the nozzle, so then the air doesn't leak out, right? But what happens if you let go of that nozzle? Because of surface tension of the balloon, right? Once you let go of the nozzle, all the air you just put in the balloon will start to leak out quickly. Very similar to what we see in the actual alveolar cells. As air enters, it can expand the lung, but surface tension has a tendency to make the alveoli collapse and then eject the air out. So in order for us to have nice, easily opening alveolar cells, we need some way to decrease the surface tension. And we can't stretch it like we can with a balloon. What do we have to decrease the surface tension? Surfactant. Surfactant is a detergent-like substance produced by our type 2 pneumocytes. The main purpose of surfactant is to reduce surface tension on the alveolar cells. therefore preventing their collapse. Now, the bad thing is this: your respiratory system doesn't fully develop until later in gestation, the last trimester. So if you have a baby that was born, and nowadays we can have babies that are viable up to 6 months of age, right? If you're born at 6 months of age, your respiratory system hasn't had a chance to become fully viable yet. So surfactant at that point hasn't been produced. It's hard for the baby to breathe on their own. In the old days, we would give them 100% oxygen under great pressure, all right? Not just atmospheric pressure, but we increase the pressure, maybe 2-3 times, right? Atmospheric pressure and 100% oxygen. What happens then? Because of that positive pressure, we can force the alveolar cells open. Perfect, right? The problem is oxygen toxicity. Because we're putting so much oxygen in there. Remember, normally at 1 atmosphere, and I should have the numbers here, right? Normally at 1 atmosphere, here's Dalton's law right here, right? So I'm just gonna move ahead. Dalton's law, right here, states that the total pressure of a mixture of gases is the sum of all the individual pressures of each gas. What the hell does that mean? That means in our environment, we don't just have oxygen. We have a lot of nitrogen, a lot of oxygen, and we have some trace amounts of carbon dioxide and water, right? But those two are the big ones, nitrogen and oxygen. It's a mixture of gases. To get the total amount of gas, we add up all the different values for the other gases and add them up, right? So Dalton's law states this. Again, total pressure of a mixture of gases is the sum of the individual pressures of each gas, right? We know at atmospheric pressure, there's 760 millimeters of pressure being exerted at us. So at 1 atmosphere, at sea level, we say at sea level, we're at 1 atmosphere pressure. At that pressure, all of the gases in our environment added together, right, adds to 760 millimeters of mercury. 760 millimeters of mercury is 1 ATM. So all the gases in our environment exerts this force on us, this pressure on our skin, on our shirts, on our body, right? This is the pressure being exerted by all the gases combined. And now what we can do is figure out how much of that 760 is due to nitrogen. How much of that 760 is due to oxygen? How much of that 760 is due to carbon dioxide, right? Now the weird thing is this: at normal atmospheric concentrations, 79% of the gas will be in the form of nitrogen, right? Whoops. So it'll be in the form of nitrogen. So at atmosphere, nitrogen makes up almost 80% of our gases. So how much total pressure then is being exerted just from nitrogen, right? Well, that is 0.79, 79%, times 760, right? When you multiply it, nitrogen by itself exerts a force of 600 millimeters of pressure on us. Just nitrogen, right? And again, when we give you a number like pressures right here, that's a concentration of that gas. So this is how much nitrogen we have in our environment at sea level, right? How about oxygen? Oxygen makes up 20% of our atmospheric gases. So how much pressure does oxygen exert on us at sea level? 20% is 0.20. We multiply it by sea level pressure, 760, and we have this number, 152 millimeters of mercury, right? In other words, when we're breathing in and out, and we're just breathing atmospheric air, we only have this amount of oxygen we're inhaling at any one time. That's it. What happens if you give somebody 100% oxygen? If you give somebody 100% oxygen right here, that means all of what you're inhaling is oxygen. If I give it to them at 1 atmosphere pressure, then all 760 millimeters right here, so I'm just gonna write it in, right? 100% oxygen at 1 ATM. What does that mean? That means we're gonna have, we're gonna have 760 millimeters of mercury of pressure just from oxygen now. Now, why is this important? Why it's important is simple, right? By giving somebody 100% oxygen versus just normal air, look at how much oxygen I'm giving them, right? I have basically quadrupled the amount of available oxygen, all right? That's a lot. Before, this is all you were getting by just breathing normal air. But if I give you 100% oxygen through a tank, I have increased the concentration of that oxygen to this. There's more pressure than from oxygen, making it easier for oxygen to diffuse into our, right, into the red blood cells. So when we give somebody 100% oxygen, we are increasing the available oxygen from 152 to 760. That is a 500% increase in fuel, in oxygen. And remember, oxygen's fuel, right? It's oxygen and glucose. That's fuel for our body to use. Now, usually we don't give somebody just 100% oxygen at 1 atmosphere. Instead, right, when you look at somebody that might be in a shopping, out shopping, and you see them have a canister of oxygen that they're rolling around or they're carrying, right? And they have the nose kind of nasal caniculi that kind of connects it to the oxygen tank. Usually, we are giving that person 100% oxygen at 2 to 3 pressures, atmospheric pressure. What happens when you give somebody 100% oxygen at 3 or even 4 atmospheric pressure? What happens is simple. Instead of normally receiving this small amount of oxygen, now we're giving them 760 millimeters of mercury times 5 times 4, right? So we can increase the amount of available oxygen to that person from this small amount to this, a 2,000% increase in oxygen availability, right? All by giving you 100% oxygen under slightly more than 5 atmosphere pressure. With babies, when we did this early on, we would give them so much oxygen that the oxygen was able to go into plasma as a soluble gas, all right? And what happens is as it goes into plasma as a soluble gas, it started to accumulate in the optic nerve. And some of the babies became blind as a result of it. Really sad, right? And the reason why was simple. Back then, we didn't have a way of making surfactant. So you have a 6-month-old baby having a hard time breathing. The only thing we could give back then was oxygen that's pressurized. We can force the actual collapsed alveolar cells to then open up because we're adding pressure to it to force it open. Just like in a balloon, what happens instead of using your mouth, you put it into a helium tank that's pressurized. Well, that air goes in a lot easier because it's pressurized. Same thing here. By giving 100% gas under great pressure to the premature baby, we can force that alveolar cells to open up. The problem is giving them that much gas, 100% oxygen at 3, 4 times atmospheric values, right? The good news is we can open up the alveoli. The bad news is there's so much oxygen now that oxygen can become soluble, right? We know carbon dioxide is pretty soluble. If you've ever had soda, if you've ever had beer, right? Gas, that carbon dioxide gas is found in that liquid. When you open up your can of soda, you hear that fizz, that's carbon dioxide leaving that liquid, right? So we have carbonated drinks, but usually we don't have oxygenated drinks. Why? Simple. Oxygen is less soluble. It doesn't want to go into the liquid as a gas. In order to get it to become liquid, soluble oxygen, right, into the liquid form, right, we would have to increase the pressure, increase the amount of oxygen. And that's what we're doing here. By giving somebody 100% oxygen at 3 to 4 atmospheres of pressure, the amount of that gas is so great that it overwhelms the low solubility of that gas. So some oxygen goes into your plasma as oxygen bubbles, small oxygen bubbles. And then the oxygen bubbles go to the optic nerve and accumulate there, causing the babies to become blind. The good news, the babies survive. The bad news, they can become blind as a result. Now we, instead of giving babies that kind of great amount of oxygen under that great pressure, we have man-made surfactant. And that surfactant that's man-made means that we decrease the surface tension then, right? We might give them oxygen because they're still premature, but we don't have to give the baby that great amount of 100% oxygen at 3 to 4 atmospheres. We can give them 100% oxygen at 1 atmosphere. At that level, there's very little risk of oxygen going into the liquid, into our plasma. So then there's very little chance of having oxygen toxicity. Does that make sense? All right, we'll come back to it in a bit. All right, let's take a little break. Take a little break, and then we'll finish up. Hopefully we can get to this part right here with gas exchange. Next week, we'll go through the dissociation curve, and we'll finish up then, okay? Let's take a little break, and we'll see if anybody has any questions. Now, when you have some, Jose, with why can't we over-oxygenate? Now, the thing with COPD, depending on the type of COPD, right? If you have somebody with emphysema, the problem with emphysema is not the process of getting air in, right? So with COPDs, there's pulmonary fibrosis, which is a restrictive lung disease, and then there's emphysema, which is a problem with expiration. These are usually the people that we call the pink puffers, right? Why? Is because they can get air into the lung, they can't get it out, right? So what we see with people with pulmonary emphysema is that their lungs are actually very distended, very enlarged. The last thing we want to do is force more air into it under great amount of atmospheric pressures, which will then cause the lung matter to even stretch more, right? Those, and with COPD, with emphysema, the alveolar cells have actually kind of ruptured. And by giving them a lot of positive pressure, you can understandably, right? It doesn't happen much, but right, you can understandably understand that if you have 100% oxygen, I give them 4 atmospheres of pressure, usually about 2 to 3, right? You can overinflate that lung. And if there's any damage in the fragile alveolar cells, you can rupture it. That's thought 22 is up. Let me see if 22 or 23 is up. Let me see. I thought 22 is up, but let me take a look. You guys see what Blackboard did? They made it look so nice now. No, it wasn't up. All right. Thank you, Jessica. Yeah, it's right here, but for some reason it didn't get published. What the hell happened? Right. Hmm. Where did they go? Hmm. Now, I will have an extra credit assignment that we're going to do I'm going to discuss in a few minutes. And it's going to be very similar to what we did for like the blood pressure thing. 1 or 2 questions. Now, somebody had asked like why, like somebody got like a 5 out of 10 in their extra credit. Keep in mind that the numbers that you get from it, I don't add it as part of the weighted score. So even though you might think it's affecting your grade, it is not, right? So let's say you get like 5 points extra credit, should be added onto the test, right? Well, because an assignment might have been worth 10 points, right? People were kind of freaking out that they actually got a worse grade because they did the extra credit. I don't give any weights for the extra credit points. So it doesn't count at all on our weighted score. So don't freak out about like if you got like a 5 out of 10, it's not counted for the weighted score section. And that's the only thing I look at for your grades is the weighted scores, okay? So that's the thing. All right, let's see. Yeah, short answer, guys. I accept thesis answers, but look, I mean, I had students like I mentioned, right? Not in our class, thank God, but in our class, I don't think there's, and my 201 too, for some reason, there isn't quite as much cheating, but in the other classes, it was, yeah, it's kind of mind blowing how much cheating that I saw. So kind of not something, you know, and the worst part about it was just the amount of cheating for stuff that they could have easily gotten just by studying. There's a lot of anatomy here, so I'm just going to remove some of the anatomy stuff. All right, both are going to be assigned now. One's going to be due next Thursday, the other next Friday. And again, it's one of those where I give you guys lots of time because I want you to take your time and use this as a review as well. Just email me. The only way I can give you extra time on a test is if you have a written consent, right? They call it a passport from, what do you call it? Now, what I can also do, and I'd started offering this in my class in the summer, was I can give you a version of it, but you have to use Respond as lockdown browser. So, but in order for that to happen, you need to have either an iPad or you need some kind of Windows-based computer, right? All right, let's finish up as much as we can here. And we're going to finish up talking about why is this not moving? We're going to finish up talking right about this spirometry and then right compliance. So we finish up talking about the pleural pressure, right? Keep in mind that this pressure is between your parietal and visceral pleura, right? And when there's free air in it, it causes pneumothorax. So that's kind of just discuss what we've been talking about. Now we're going to talk about normal breathing cycles. What happens when you inspirate and expirate? And usually the cool thing is in a normal semester is we actually, wow, it's kind of crazy that even when we come back to school, I don't even know if I could be able to do this kind of experiment anymore. But we had these experiments where somebody would blow into a machine that looks like a nebulizer machine, right? If you ever seen a nebulizer, that's different than doing like a albuterol kind of inhalant, right? So you basically have to hold this machine next to your lip and then you blow as hard as you can. So then we can measure the amount of air you're expelling. And then you take a deep breath, the amount of air you are inspirating as well, right? That is a chart that we'll talk about in just a second. Now, in terms of respiration, we're gonna see that we're gonna need compliance, measure of the ease with which the lungs and thorax expand. The greater the compliance, the more healthy the lung, right? Because it's much easier then for us to change the pressure because it's easier for us to move the lungs and the thorax. Lower than normal compliance means the lungs or thorax are harder to expand. They're harder to expand, harder for air to get in and out, right? Usually it's caused by diseases or infections. Pulmonary fibrosis, deposition of inelastic fibers in the lung. Keep in mind with pulmonary fibrosis is a type of restrictive lung disease where air has a hard time going in to the actual alveolar cells, right? Now, with the pulmonary fibrosis, usually, and I do have a slide that we'll talk about next week about pulmonary fibrosis, about diseases in general, right? Usually we call these people, because they can't get air into the lungs, they can't get oxygen in, and they become cyanotic. Now, become cyanotic means they turn slightly blue, right? We treat these people with a lot of oxygen, 100% under great pressures. Now, the thing is this, with almost all of these diseases, we're gonna treat them very simply with oxygen and then some kind of steroid, right? To decrease the inflammation. But with pulmonary fibrosis, these are the blue bloaters, right? Pulmonary edema, respiratory distress syndrome, chronic bronchitis, even kyphosis and scoliosis can make it harder for your thoracic cell wall to increase in size. Keep in mind, kyphosis is when you see a person that's hunched over, right? So the thoracic vertebrae is moved very anteriorly. If you are hunched over like that, it's really hard to expand your lungs. Makes sense, your compliance will be severely affected, right? Measurement of the lungs is used. Now, this isn't the same thing as when we have breathing exercises and there's low, some of you guys have seen that where you breathe into a tube, you inhale and exhale, and there's this little like ball in there, you're trying to move it up. This is not spirometry, or that is not. This spirometry requires a very big machine, right? And it's gonna measure very carefully the amount of airflow as you take a deep breath in and then do some exercises, right? So let's talk about what these are. So there's something called tidal volume, amount of air inspired or expired with each breath. This is normal, quiet respiration. Then we have an inspiratory reserve volume, amount that can be inspired forcefully after inspiration of the tidal volume. And it's a measurement of the elastic nature of the lung. So with tidal volume, it's just normal breathing, right? Just normal breathing in and out. Usually we do this by pinching your nose and then making you breathe through your mouth. And then there's a machine, there's a thing you hold, and there's a machine that kind of measures the airflow as you breathe in and out, right? So tidal volume, quiet respiration. So right after you have a nice quiet inspiration, then the person tells you take an even deeper breath. That's your inspiratory reserve volume, right? Then with expiratory reserve volume, after you have quiet expiration, usually I have that person, when we did it in class, after they expire like this, I have them stand up and really forcefully expire as much as they can. That's our expiratory reserve volume. The weird one is this, residual volume. Volume still remaining in the respiratory passages after even the most forceful expiration, right? Now, we talk about the respiratory. This is one of the only ones that are highlighted for a reason. So here's what normal respiration is, right? You take, it's about 500 mLs in and then out, in and then out. Your inspiration, maximal inspiration, or otherwise known as the inspiratory reserve, is you take a nice small breath in, and then you stand up and you breathe as fast as you can for as long as you can, right? Now, that's our inspiratory reserve. We want this inspiratory reserve to be very high. It allows us to deal with any changes in the environment at a better way, all right? Then you exhale it out all the way down. Then for a couple breaths, I have you just kind of normal, quiet respiration. And then after you exhale a little bit, then I have you stand up and I force you, don't really force you, but I try to, help you kind of expirate even beyond that quiet expiration. This is maximum expiration. Maximum expiration is a measurement of a healthy recoil. Maximum inspiration is a measurement of healthy compliance. All right? Now, the weird thing is this. We always have this residual volume, right? This residual volume is a little bit of air that is basically trapped into the real deep areas of our respiratory system in the alveolar cells. Why is this important? Simple. Remember when I mentioned that alveolar cells are like very small balloons, right? And with very small balloons, it's very hard to open them up. Probably the easiest way to open it up then is to make sure there's always a little bit of air inside. So then there's slightly inflated, all right? Ever slightly inflated all the time. That way you don't have to force air in and force it open. There's always a little bit of air in there, keeping the alveolar cells from collapsing. That's that residual volume, right? Making it easier then when you take your next breath in, well, your, alveoli are partially inflated. Makes sense, it's much easier for air to go in then. Right, now, I do want you to know a couple things, right? Minute ventilation is tidal volume times the respiratory rate. It gives us a value similar to the cardiac output. How much airflow do we have, right? Now, I'm not going to ask you to remember that. I want you to know this. What is the difference between anatomic and physiologic dead space? The dead space is simple. Any region that is void of alveoli. Because it's void of alveoli, that region has no gas exchange, right? That is considered the anatomic dead space. For a person of the same height and similar build, the anatomic dead space of two people of similar height and similar build should be very similar, right? So starts off from the nose and nasal cavity to all parts of the pharynx and larynx, the trachea, to the bronchi, to the bronchioles, to the terminal bronchioles. All these areas have no alveoli, so there's no gas exchange. That's dead space. So the only region where we see non-dead space, where we see respiration then, is a region that contains alveoli. Perfect, right? Now, the physiological dead space is the combination of anatomic and any dead space due to trauma, right? It can be due to lung damage due to previous infections. You have You've been a smoker your whole life, and now you have some kind of disease, right? Fibrosis in the lungs. Well, you're going to have a lot of physiological dead space because of it. Or, God forbid, you get a real bad case of coronavirus, right? We know that the mortality rate's probably about 0.5 to 1%. So not really high, right? But it seems like it can infect just about everybody. So what happens is the people that do get it, they might not die, but that doesn't mean they're not scarred, right? They might have scars from it that will follow them the rest of their life. So if those scarring can affect the lung matter, then the physiological dead space will be increased in that person, right? If your physiological dead space is the same as your anatomical dead space, then your lungs are very healthy. That means there's no physiological, no trauma, no disease that's causing any increase in your dead space. Right. Now with Dalton's law and Henry's law, right? Dalton's law was kind of what we figured out. Now keep in mind, right? There are times when we might have to treat somebody by putting them into a hyperbaric oxygen chamber. And this is the reason why it works, right? You guys know that 95 to 99% saturation is normal, right? We kind of know that. 95 is actually kind of low. We'd like it 97 to 99% saturation. Do you guys know that your O saturation can be above 100%? Right? When we're measuring your oxygen saturation by the finger, right, monitor, we're measuring the oxygen saturation of your red blood cells. So the highest that can go is 99%. So how do we get it to over 100%? And is Dr. Lee crazy? Right? Here's how we can get it to over 100%. And we only do this in very specific situations. One of it is when somebody has carbon monoxide poisoning. What happens is this. It is due to these laws, right, that we can go above 100%. Henry's law is the concentration of a gas in a liquid is determined by its partial pressure and its solubility coefficient. Meaning, we can put a gas into a liquid, all right? Sometimes for a given gas, it's a little bit easier versus another gas. In terms of Henry's law, all gases can be put into a liquid itself if we have enough partial pressure. In other words, partial pressure is concentration of that gas. If we can increase the concentration of that gas, the pressure of that gas to such a great amount that it overwhelms its low solubility coefficient, we can push that gas into liquid. Example, we know carbon dioxide right here has a higher solubility coefficient. It doesn't take a lot of carbon dioxide then to push that gas into an energy drink, to push that gas into a soda drink. All right, what happens then? You carbonate that liquid. Why? Because that gas has an easier time, all right, because of its high solubility coefficient. It wants to more readily go into the gas form, into the liquid. Oxygen has a very low coefficient. That's why you never heard of an oxygenated drink, right? Why? Because it has a very low coefficient. In order for oxygen to be pushed as a gas into the liquid, because of its low coefficient, you need a huge amount of it, right? We need a big amount of oxygen just to push a little bit of it into solution. That's why you never heard of an oxygenated drink, because you would need so much oxygen that oxygen's explosive, right? It's very dangerous at that point. So when do we have the ability to go beyond 100%? Hyperbaric oxygen treatment. What happens? I can give you 100% O2. That means as you're breathing in, that's 760 millimeters of mercury, all from just oxygen. Not even that. Now, because you're in hyperbaric treatment, I can increase it to 7, 8 atmospheres. So then it's 760 millimeters of mercury of oxygen times 7 ATMs. I can increase the partial pressure of oxygen. Normally, at physiological atmospheric sea level, it's at 150 millimeters of mercury. But by giving you oxygen at 100%, at 7 atmospheres, I can increase it from a 150 to almost 5,000 millimeters, all right, of mercury. I can increase your available oxygen 3,000, 4,000%, right? When it's that high, oxygen can go into your plasma, right? As it goes into your plasma, well, the first 99%, right? Oxygen is going to saturate your red blood cells, and then you're going to have some oxygen be found as a gas in your plasma. So then your oxygen content can actually go above 100%. And the reason why we do this is carbon monoxide poisoning, right, is very hard to treat. Carbon monoxide really likes to bind to red blood cells. So it's really hard to kick the carbon monoxide out. The only way you usually can is to give you such high amount of oxygen that it forces the red blood cells to release carbon monoxide. And even then, right, we need even more. And that oxygen then goes as a gas form, increasing your levels above 100%. Right. Physical properties for gas exchange, right? So what diffusion gases through the respiratory membrane depends on 4 factors: membrane thickness, diffusion coefficient of the gas, carbon dioxide 20 times more diffusible than oxygen. And again, right, because carbon dioxide is 20 times more diffusible, you don't need as great of a concentration change, concentration gradient for carbon dioxide to go in any one direction. We're going to see there's not going to be a huge concentration difference for carbon dioxide. There will be for oxygen, right? Surface area, diseases like emphysema, cancer, fibrosis reduces the available surface area for gas exchange. And then partial pressure differences. Gas always moves from area of higher partial pressures to area of lower partial pressures. Keep in mind, what is partial pressure? Partial pressure is a way of measuring the concentration of the gas. Right. We're almost done. I don't think we'll get to that one. I'll ask the extra credit next week. All right, relationship between alveolar ventilation and pulmonary capillary perfusion. So we need a relationship between air movement into alveoli and blood movement into the pulmonary capillaries, right? Increased ventilation is directly related to increased perfusion in that area. What does this mean? Simple, right? It makes sense that the more airflow into certain areas of our lung, the more blood flow to that same area. They're directly related. So the more airflow into an area of the lung that's not damaged will cause more blood flow to that area of the lung, right? Why? Because there's, we want area that's very well ventilated, has a lot of oxygen in it. We want blood to go to that area so then we can pick up the oxygen. In other words, the opposite's also true, right? We are going to detour or shunt blood away from regions with poor ventilation. Why do people survive? And how can that football player that had a pneumothorax, right? My student that had a completely collapsed lung, how come she was able to walk up the steps and talk to me, even though she had one lung that was completely collapsed? It's because of this, right? When we have a region of lung that is collapsed or damaged, right, there's very little ventilation in that area. What we're going to do then is vasoconstrict the blood vessels going to that area. Why bring blood to regions that are not ventilated? You're not going to have gas exchange in a region, right? You're not going to have oxygen there. You're just going to pick up lots of carbon dioxide. That's not good. So what we're going to see is that we are going to have a shunting effect. Areas that are poorly ventilated can be due to collapsed lung, can be due to, right, some kind of trauma, right? It can be due to disease. It can be due to an infection. Anything that causes decreased air movement, decreased ventilation, that's air movement, right? Anything that decreases ventilation means there's no free, good air in that region. That also means we're going to shunt blood away from that region by vasoconstricting blood vessels that would go there. And then vasodilating that blood vessels that goes to the healthier area where there is ventilation, right? Again, right, this shunted blood is something we see, and it allows people to survive a collapsed lung, right? If it wasn't for this, then blood would move into that lung matter that's collapsed, pick up all that carbon dioxide. Half of it will go to that area, half of it will go to the good lung. Well, now you're not oxygenating as much as you should. You're going to become cyanotic. And then, right, you're going to become hypoxic. Not good. So what we then do is and this is a big one, low PO2 in the lung means there's very little ventilation in the lung, in that area of the lung, right? Low PO2 causes arterioles to constrict, especially in pulmonary circulation. So then blood is shunted to regions of the lung where the alveoli are better ventilated. Again, low oxygen content in the lung matter causes a vasoconstriction. So then you'll have areas that are poorly ventilated. That area will have poor blood flow. The areas that are well ventilated, vasodilate. And now you're going to bring more blood to that area. Why? Because there's lots of oxygen there, right? Now we can bring more blood flow to the area that is well oxygenated. Perfect. The weird thing is this last one right here, right? It's the opposite in systemic tissue, right? In pulmonary tissue, low oxygen means you have some kind of problem, right? You can't get air through that area. It's an issue. It can be disease, it can be trauma. Either ways, it's causing you to have low oxygen in that area. Now, in systemic tissue, it's different. Low oxygen, low PO2 in systemic tissue is a sign of activity. Remember when I said oxygen is fuel? Oxygen is fuel for aerobic respiration for our cells. So if an area of your body, let's say you're, jogging, or you're doing exercise like weightlifting and you're doing legs. So your legs are the only thing you're working out. Well, what happens? The muscles are contracting a lot more in your legs. If they're contracting a lot more, what do we need? Oxygen. So it makes sense that the skeletal muscles in that area have very low oxygen content. Low oxygen in systemic tissue is a sign of activity. So if it's a sign of activity, wouldn't we want to bring more blood to that area? We do. So in systemic tissue, it's the opposite of what we see in the lungs. Low oxygen is a sign of activity. We vasodilate the blood vessels that are leading to the area that's more active. So then we can bring more blood, more nutrients to that area so we can sustain our contractions. Completely different than this, right? So there's always that kind of dichotomy between what's happening between the pulmonary circuit and the systemic circuit. Low oxygen in pulmonary circuit, sign of some kind of danger, sign of some kind of, right, insult, right? Not good. Well, you're going to vasoconstrict that area. Vasodilate area that has high O2, right? In systemic tissue, low oxygen / low PO2 is a sign of activity. If you're more active, you want more blood to go that area. So when you have low PO2 in your systemic tissue, you vasodilate to bring more blood flow there. Perfect. All right, this is what we call, right, a shunt right here. All right, we will go through this and then we'll stop. Sorry, I lied. Take a look right here. Here's the normal gas exchange area right here. So in your lungs, you have, right, the right ventricle sending blood into the lung matter, right? Then as you inhale, the PO2 in the lung, take a look, right? Normally in inspired air, about 160 millimeters of mercury coming in, right? Now, why 160? Well, usually we say it's like, 21% times 760, right? That means that when we first inspire, this is the amount of oxygen available to us. This is the amount of, right? And then as you breathe it in, and I think there should be carbon dioxide right here, all right? As you breathe that oxygen in, it goes into your alveolar cells, goes in, right? And now the PO2 dropped here, and it goes to 104. Why is there a drop in PO2? Right? 160 when it comes in your nose, and by the time it gets to the alveolar cells, it dropped to 104. Right? Why? More importantly, right, it's still very high. So what happens? There's a concentration difference between the PO2 in your alveolus and the PO2 in your blood. PO2 in blood is at 40 millimeters of mercury. PO2 in alveoli, 104. A lot. What happens? Oxygen diffuses from the alveolus into the red blood cells. As it does so, the PO2 matches the alveolar PO2 because now it's in equilibrium. How about PCO2? PCO2, right, in your pulmonary vessels is at 40 millimeters of mercury. PCO2 in the alveolus is only at 40. So not a big concentration difference, right? Not compared to what we see with oxygen. So why does carbon dioxide want to leak out? Is because carbon dioxide is more diffusible and it doesn't require as much of a concentration gradient then. So any concentration gradient will cause that carbon dioxide to move from our bloodstream out into the alveolus. Perfect, right? So then our PCO2 is in equilibrium as well as our PO2, right? Now, here's a weird thing, right? When you expired air, your PO2 is at 104. When I measure the amount of oxygen in your lips as you expire, as we measure it as you exhale out, it magically moved to 120. How did we pick up oxygen along the way? Right? In the alveolus, it's at 104. So if I measured it in your lung, the amount of oxygen, 104 millimeters of mercury. But when I measure it in your mouth during exhalation, it went up to 120. Right? This is not a mistake. This is something that does happen. My question is, why does it drop? Why does it increase? And it's not a mistake, right? If you can answer that, and I will have something to fill out, right? If you can answer it, then you will get some points added to your test. Right? Now take a look right here, right? As we go down, take a look at oxygen levels. The PO2 drops. Why does it PO2 drop here? Is because the bronchial arteries and bronchial veins, therefore, are going to fuse and bring deoxygenated blood into your systemic circulation, dropping the PO2 from 104 to 95. When we go into the left ventricle and we bring that oxygen and carbon dioxide into the tissues, what happens? Well, the more active the tissue, the lower the PO2. So now the PO2 is 20. The PO2 in the red blood cells and the bloodstream is at 95. Huge concentration gradient. Oxygen is going to go from the bloodstream into the interstitial fluid and then into your cells. Carbon dioxide is going to go in reverse. All right. Next week, we'll talk about why we produce carbon dioxide. You guys ever wondered that? Why do we produce carbon dioxide? All right. We know we talk about it all the time. You exhale carbon dioxide. Where does it come from? We'll talk about it next week. Next week, we'll talk about the dissociation curve, which is really cool. Right? All this stuff, gas exchange, and then diseases. All right? Any questions? Not really? Okay. Then I'll end the meeting. Thanks for coming, guys and ladies. Guy and ladies. All right.